Good afternoon, everyone. My name is Chobadegi. I am a very close colleague of Nevanka, and I say this because we have worked together as co-chairs at the European Cancer Organization. We were co-chairs of the Quality of Life and Survivorship Network, and we do understand pain from different perspectives, but with the same focus. The focus is on the patient centered care or people centered care, if you would like to, that way. It is a true pleasure to be invited again to this training school in Maribor. And it's such a pity, and I am very sorry about it, that it's the second time around when I cannot be there with you in person. But may I reassure you that I really love the idea to visit Maribor, and the tradition of this training school that Nevanka puts together every year, it's always thrilling. So hopefully next time, as in the Hungarian folk tales, the third time is the right time, I will be able to be with you in the room, to feel you, to discuss with you, and to, you know, have the interaction that makes things possible. For this moment, I would like to have your kind attention because today we will going to discuss the psychosocial aspects of the cancer journey, cancer care, and I am originally from Romania, from Transylvania, and that also means that my perspective is very much based on the research that I have been doing from 2001, the last 24 years. We have been doing this with my team, and also on the European context that I am very much familiar with and I work with as part of our mission at the European Cancer Organization in Brussels. So you will have a double sandwich, and mostly I will try to keep it basics and also try to give you our strong experience together with what is really new in this area. So hopefully it's going to be useful. And now I think I am ready to start the presentation. The topic of the discussion today are the psychosocial needs of cancer patients, or the absent voice, as I like to call them, or the absent voices when we refer to the psychosocial aspects of healthcare, especially cancer care. I'm very sure that to many of you in this room, it's very clear that cancer, it's not just a flesh and bone kind of disease. It's not merely a physical disease. It is a very profound life experience with many changes that are impacting every part of the person's existence. And in that regards, the psychosocial needs in cancer care are referring to a very broad spectrum of emotional and social suffering, emotional and social pain, like, you know, the cancer distress, depression, anxiety, adaptation disorders, some kinds of that, and of course the almost never going away kind of C stigma or the impact of the cancer stigma. And I am very sad to say quite in the beginning that in many places, including Europe and parts of Europe, despite the advancements in cancer treatment and therapies, the psychosocial needs are still going often unmet, unsatisfied, which still means that we still cannot treat the cancer patients like a grown-up person, and we are not yet fully patient focused and cancer focused, because in some places like Romania, where I come from, the situation is and has been particularly challenging in the last decades, actually. First of all, with the noted lack of the sufficient professional in psychosocial oncology and especially in social work, social care within the oncology settings. And based on our data, less than 5% of patients in this country receive any kind of psychosocial support. Yeah, less than 5%. And that also means that psychosocial care is often not part of the standard treatment plans. And those professionals, oncology professionals that are working with cancer patient needs, are frequently not having the adequate training in the psychosocial and communication issues that are related to the cancer, which of course is impacting the general picture of quality of life, cancer distress, and many other things that we are going to discuss topic by topic today. But if we just for a second move away from the cancer experience and the cancer journey, in the wider spectrum across the European Union, especially after the COVID situation, mental health challenges are quite widespread. According to a recent Eurobarometer survey from 2023, 46% of the Europeans had experienced an emotional or psychosocial problem in the past year. But shockingly enough, half of those who experienced such issues, psychosocial mental health challenges, did not seek professional help for many reasons. But one of them is actually the accessibility or the access to this kind of professionals, psychosocial professionals. And that also means that we, here in the beginning, need to take not just the broad, the wide, and the very narrow, very specialized take on cancer, but we also need to talk about the critical need for psychosocial oncology in 2025. Now, by research, it is very well understood that psychosocial factors are playing an important role in the cancer journey. The objective characteristics of the disease, of the cancer trajectory, are often very uncertain indicators of the patient's behavior and of the patient's emotional world. This behavior and emotional experience is many times, of course, controlled by all the psychological dynamics that are in us and in our lives and in our interaction with the wider world outside us. First hand. And the second thing that's also quite important, that open communication about cancer, including diagnosis, treatment, prognosis, is or can be highlighted as even more important. And sometimes it is being associated with cancer mortality in some advanced stages. So having the adequate addressing of the psychosocial needs is not just merely a topic of comfort giving. It's potentially impacting disease outcomes in some groups and some forms and some stages of the cancer patients. And it's very important to highlight when we talk about the critical need for psychosocial oncology. Also, there is an urgent need to develop psychosocial oncology services much more, much better, with a quality focus across Europe, taking into account especially the inequalities and inequities in having access to psychosocial oncology services. Because having this kind of psychosocial oncology services means that we can overcome multiple barriers, including professional training deficits, the always present integration challenges, and other factors that are limiting the discussion and also the open choices about the cancer disease. And when we are talking about the critical need for psychosocial oncology, of course, we are always talking about the vulnerable groups facing cancer, like for example, elderly and very young patients who are particularly affected by the inadequate psychosocial support, both in the cancer context and also in the broader mental health services context across Europe. So, this is how we start our discussion, and I would like to also just get a drop of the research project that forms the background from which I am speaking to you today. So we have had many projects in Romania, but one of these, first of a kind, was the APSCO research project, the Assessment of Psychosocial and Communication Needs in Oncology, which actually was initiated against the backdrop of significant unmet needs here in Romania. And it was a wide, nationwide assessment-based report on this often unattended psychosocial and communication needs. We actually used the so-called repeated cross-sectional design, meaning that every 7 years we are, making this kind of assessment on a nationwide level in the major Romanian cancer centers. And here you can just see an example from 2 points in time. We actually started in 2001, so 24 years ago. And then we had the next wave in 2007 when we joined the European Union. It's really shortly after that accession, and we had a few hundreds of patients in our research. And then in 2014 and then on. So we had by then a few, more than 1,000, and by today we are working with the data of more than 5,000 cancer patients from Romania. And the main objective of APSCO and later on of the CanPrim project was to measure and analyze cancer distress in the clinical context, in the treatment context, but also when patients were transitioning out of the treatment into the survivorship, into the primary care, and we were always assessing quality of life, and we were trying to identify how cancer diagnosis, cancer distress, it's profiling the experience of the cancer journey here in Romania, and to make a comparative analysis of the psychosocial factors also in time, understanding the context, the situation, especially the socio-economical situation before and after significant periods and transitions here in the country for the cancer patients. So just a few more words about the methodology that we used. Of course, we had a questionnaire-based assessment using multivariate statistical methods as it should be. And we had actually quite a list, a chunk, a package, a battery of validated assessment tools that were employed to capture the lived experience and the very complexity of the psychosocial experience of the cancer patients. And here you can see the list, or at least the most important instruments that we used in our list. We used for the quality of life, we used the FACT G4. Then we use the back depression inventory, the illness intrusiveness rating scale, the coping strategies inventory, the self-efficacy scale, the sense of coherence scale. We also use the anxiety trait anxiety inventory, emotion thermometers tool, hostility scale. We use the social and emotional loneliness scale, and also the dysfunctional attitude scale. I just listed all the scales because they are wonderful validated instruments which are allowing to have a comprehensive assessment of the persons affected by cancer across multiple psychosocial dimensions that are relevant and important to our cancer patients. We will start with one of them, which is quality of life. And I am very, very sure that you are familiar with the joke that not even those who believe in heaven want to go to heaven. And most of the time it's true, but in cancer care, adding quality, I repeat that, quality to years is considered at least as important as adding years to life. And this is a very strong patient preference because patients are often leaning towards treatments that are improving quality of life over those treatments that are only targeting survival, especially the elderly patients. So when we are talking about years to life, we're also talking about life to years. And in my experience in the last decades, it's very clear that patients want both, and they have to choose between them. Most of the time, they're choosing quality of life. And this is why, at least from the 80s, quality of life has been used as a global indicator of the efficiency of clinical trials, of cancer treatments, and many other things. But also, this is a multi-dimensional concept and instrument that is at least four factorial. For in the case of the FACT-G, it includes the physical well-being, the social well-being, family well-being, emotional well-being, functional well-being, and all these are adding up to a global quality of life, which in this case ranges from 0 to 108 points, and which indicates that higher scores are better quality of life. And these are the instruments like FACT-G4 that are very well validated instruments and translated in many languages. So it's very important to have the history, the roots, the power that they give voice to the patient experience, lived experience. And now let me just show you an example in a comparative manner on this. We are already familiar with the setup of the quality of life in the FACT scales. So here you can see that usually the quality of life scale, the results scores for cancer patients was quite low or very low. And when we compare them, we can see some kind of changes. But these changes that you can see here in the table are mostly statistically significant changes. They are not the so-called clinically significant changes that do have a meaning for our patients. And let me tell you and highlight so very much that even the patients don't call it clinical significance or statistical significance or statistical significance versus clinical significance. Our patients are very much aware of these differences and of these changes. There is a very clear distinction in their experience that highlights that patients many times are minimizing the negative evaluations. They're shifting the negative evaluations, but they are enthusiastic about even a very slight positive change. So this is the mindset, and it's very crucial to understand the concept of clinical significance versus or together with the statistical significance when we are trying to have an interpretation of the quality of life, when we assess that from the patients. Because, for example, in the FACT-G, for these four subscales, there is a threshold of the difference of 3 points to obtain clinically meaningful significance. But as you can see from our results from the same period, this meaningful experience or this meaningful clinical significant change was not present. We could see some kind of improvements here, but there were only statistically significant, not clinically significant necessarily per se, which means that yes, important changes has maybe happened, but much more transformations are needed at the level of provided medical services to include the psychosocial care and to have this meaningful, clinically significant breakthrough when we are assessing quality of life in cancer patients, especially in low and middle income contexts. Based on our study, but I'm very familiar with many other studies that are proving and showing the same, we have identified some very strong significant factors that are influencing quality of life in cancer patients. One of them is age. Elderly patients over 65 consistently reported the lowest quality of life on a global level and also on the subscale measures level. And this held true for all aspects of quality of life. And as such, it indicates a very particular vulnerable population requiring targeted quality of life interventions. So this is the first one. The second one is the cancer stage. I am very sure it's very obvious that patients in later stages generally are reporting poorer quality of life and physical functional well-being, of course. But there are some exceptions, not too many, but there are some. But social well-being tend to have another trend. Social well-being in our research was potentially lower in the early stages of the cancer journey due to the uncertainties about the disease trajectory and outcomes, and it kept growing as the stages, changed. And another important, significant influencing factor, together with age and cancer stage, was the financial status. And this is why it's so important to understand the economic constraints and the financial toxicity of the cancer experience. Patients who felt that they lacked the resources to meet the basic necessities of their lives. So this is what we call, the experience of being poor without no resources. This kind of patients actually, at this level of the poverty, they reported lower quality of life in all our measures. And the percentage of these patients in some groups, in some places, in some communities, actually are sometimes increasing. And this is suggesting very much so that economic factors may be increasingly impacting the cancer experience. So we need to take a close look to that, always. Physical activity, it's a very well-known twin brother of quality of life, as we know that physically active patients scored significantly higher on the quality of life scales compared to the inactive peers of them, and that regular physical efforts, they are diminishing the percentage of those who are reporting poor quality of life. So also highlighting here a need for a potential quality of life related intervention for sure. And also we have had other factors, significant factors, influencing quality of life in our study, like the self-rated health, which is also sometimes called the subjective perception of the health status, illness intrusiveness, or the degree to which the disease interferes with various life domains of the patient. And here I must also say the factors that did not show significant differences in quality of life between groups, because this finding can help us prioritize the interventions of quality of life by focusing on the factors that most strongly impact the quality of life among cancer patients and the highest impact they can have to change the poor quality of life. So the factors that did not show significant differences were sex, residence, religion, ethnicity, the status of the diagnosis disclosure, whether the patient was informed personally or not about their diagnosis or their diagnosis, tumor location, and substance use. And now we are dwelling in another big chunk of the lived experience of the cancer patients. After quality of life, now we are going to talk about depression. Depression is another critical psychosocial needs category in cancer patients. And international surveys are indicating quite a wide range and ratio of depressive disorders and symptomatology in cancer patients, which are, ranges from 1.5% to 60%. And sometimes in palliative care, it can go up to 75%. And this wide range reflects not just the different assessment methodologies, but also the cancer type, stages of the disease, and the context of the disease in which we are having, cancer. Nevertheless, it's very clear from all the research that we have in this area that depression is highlighted as an independent health endangering factor in cancer patients as well, may I say. And it's a depressive symptomatology, it's a factor alone that can cause deterioration in quality of life and significant functional deterioration as well. And I have to confess here that Still, the notion that depression is normal when you have cancer, it's something really awful, because if it's untreated depression, it contributes very much to the therapeutic nihilism and limits treatments, options, alternatives, and also the collaboration of the patient with the caring and treating team as well. So in our UPSCO research, we have used the Beck Depression Inventory, as it's measuring many aspects of the depression slice, including the social isolation, fatigue, inability to work and feel joy, anhedonia, and self-blame, of course. And it's actually providing a kind of group tiers categorization, like no depression, group mild and moderate depression, and severe depression, as you know. So here I must say that, consistent with the quality of life findings on age, patients over 65 years old and older were the most affected group regarding depression in cancer. That is again further highlighting the burden and the vulnerability of the elderly cancer patients group. Here you can see again the key associations and characteristics that we found in our study between clinical depression and several other psychosocial factors. I will start with high illness intrusiveness. Depressed patients reported cancer impacting more areas of their lives compared to those who were not in a clinically depressed situation. So the cancer disease was experienced as more intrusive across the whole 13 life domains measured by the illness intrusiveness scale developed by WHO. The other statistically significant association was with behavioral inhibition. It is very important from the behavioral medicine point of view. Patients with clinical depression showed higher score on behavior inhibition, indicating patterns that are very much in the disadvantage for psychosocial adaptation for people affected by cancer. Emotion-focused coping. Usually it has a very good stronghold and instrument when it's used in the right way, but higher use of the emotion-focused coping strategies was associated with depression, because understandably, why we are using some kind of these strategies that can be helpful in uncontrollable situations, crisis situations, overusing them or higher use of the focused coping can actually, trigger more depression. Another category are the dysfunctional attitudes. Depressed patients reported more dysfunctional attitudes, reflecting very much so cognitive distortions that can maintain many times or even can chronicize the depression that they are experiencing. And another significant association was with the low self-efficacy. Patients with clinical depression in our study faced difficulties that are reflected in lower self-efficacy scores. And as we know, self-efficacy is a decisive factor in adapting to cancer. So here you can see like a very, very important network of psychosocial factors that are actually associated with depression experience in cancer and their characteristics as well. And as a next slide, and the last on depression, I will share with you more associations. We also have the high vital exhaustion. This is a key indicator of chronic stress usually, and the risk factor for disease onset as well. So depressed patients show significantly higher vital exhaustion. Also high anxiety, stress, and anger. Using tools like the emotion thermometers, and for those who are reporting higher levels of these emotions, these negative emotions, has also an association with depression. So, as we can see more and more clearly, depression doesn't go along alone, solo. It actually has all these layers of other psychosocial factors that are burdening more suffering and more challenges as well. And the high need for help, this kind of experience, is also associated with depression in the sense that patients with clinical depression reported, of course, a significantly greater need for help, with average scores nearly double, yes, double, to those without the clinical depression. And so all these multiple associations are demonstrating the very complex nature of depression in cancer patients, and also highlights the need of very good quality, highly comprehensive assessment of the cancer patients when we are talking about the psychosocial needs. And also, assessment is not enough. We need to have a very clear, multifaceted interventions that are addressing all these various and diverse and very much personalized contributing factors to the psychosocial needs. So I mentioned to you that we were also interested in studying the impact of the diagnosis disclosure, because yes, in Romania we did have a profile of cancer diagnosis non-disclosure, concealing the medical information from patients for the sake of the patient. It's less and less present, but nevertheless, it was very clear from our research that it did not benefit the patient at all on a psychosocial level. From our key findings related to cancer diagnosis disclosure, I can tell you that uninformed cancer patients had a higher probability of developing severe forms of depression, so no hope at all. Informed patients about their cancer diagnosis generally presented, asymptomatic forms of depression. And these findings do not validate actually the mistaken and earlier assumptions that non-disclosure of cancer diagnosis is in favor of the patients, and it's in favor because they might develop depressive and anxiety symptoms. It's exactly the way around that. And also here I must say that uninformed patients also showed higher levels of pessimism, higher levels of hopelessness, which are significantly aggravating their situation in regards to trust, decision, quality of life, all of these that are important in the collaboration with the medical team. So this finding are challenging actually the traditional practices in many cancer settings, medical settings, not just in Europe, where diagnosis information is withheld from the patients, and in the quest to protect them from distress. Our data actually on the impact of the diagnosis disclosure on depression suggests that these practices may actually contribute to the worsening of the psychological outcomes in the cancer journey. Also, as I said, we were measuring other important psychosocial factors as well. Beyond quality of life and depression, our study UPSCO also explored a range of other psychosocial dimensions like illness intrusiveness that we mentioned about. And as noted earlier, the illness intrusiveness scale was strongly associated with depression and lower quality of life. And also a very quite unique finding in this sense was, in the Romanian context, was the difficulty in discussing the sex life in cancer, suggesting a very strong cultural taboo within the doctor-patient relationship on that topic, which is a very important psychosocial topic. The other very important psychosocial factor that we measured, was in regards with the coping strategies using the Folkman-Lazarus coping strategies inventory. And the study looked at different strategies and the associations between them. Of course, the effectiveness of this kind of coping strategies are very much personalized. Um, Usually the pattern being that the problem solving focused coping often it's needed for the controllable situations, and the emotion focused coping for the uncontrollable situations. The self-efficacy and the sense of coherence factors, psychosocial factors, they are of course related concepts. And self-efficacy, as we understand from this Schwarzer scale, is a belief in our ability to handle situations and is important for adapting in cancer. And the sense of course it's a much more stable personality trait, should I say, related to our ability to comprehend, manage and find meaning in the life events. Like one of the biggest life events for us is the cancer experience. Both of these, self-efficacy and sense of coherence, were lower in depressed patients, of course. And then we have anxiety, stress and anger, as I mentioned before. And these negative feelings, these negative experiences, emotions were significantly related to higher clinical depression level. And I must say that in this research, we have validated the very quick, rapid visual scale assessment of the emotion thermometer tools, which also means that we have an app for cancer distress screening and management in Romanian and Hungarian since 2016 in Romania. There are some other psychosocial dimension, additional ones like hostility and social distrust. And here depressed patients reported higher scores, indicating greater difficulties in interpersonal trust and social connections. And trust and decisions and communication, they go hand in hand. And as the loneliness experience of the cancer patients shows, elderly patients, particularly widows, were highlighted as most affected by the lack of the family support in cancer. We also have the dysfunctional attitude scale, as shortened and as used and measured in a shortened version from the Weizmann scale. And here depressed patients also had higher scores, as we mentioned earlier. The need for help is another psychosocial dimension that we can directly measure with the emotion thermometers tool developed by Alex Mitchell from UK. And as we stated earlier, depressed patients reported a significantly greater need for help, highlighting the importance of identifying and addressing unmet support needs. So, as you can see in our study, all these highlighted psychosocial factors are very much interconnected, and they can mutually amplify the negative experiences. And actually, this interconnection between all the psychosocial factors are creating a very complex web of possibilities and of influencing that can have a significant impact on the quality of life of the people affected by cancer. They can potentially influence cancer outcomes like progression or true progression, create mutually reinforcing cycles of psychosocial distress or psychological distress, indeed complicate treatment response and the adherence level, the collaboration with the cancer care team, and of course it can affect the social and family relationships in a very, very complex and deep way. So what we succeeded in capturing with this assessment tools, it's not just the complex relationship between the psychosocial factors, because you might think that, well, this is only one thing and let's listen to the patients and get rid of that and let's solve it and that's it. But that's not the way it goes. We are very, very complex feeling beings with a very complex emotional and interpersonal networks and lives and dynamics. So this complexity actually is underscoring the need for comprehensive approach assessment and an integrated intervention always as a standard approach rather than focusing on a single factor in isolation when we talk about the psychosocial needs in cancer care. So what I just want to say that there is very clear proof that interventions in the psychosocial aspects of cancer need to address all these multiple dimensions to achieve the meaningful improvements in the patient well-being uh, and in the surviving experience or the palliative care experience. So, as I'm approaching to the end of my presentation, I would really just highlight a few challenges in meeting these goals based on the results. And now I just shared with you spot understanding from our research from Romania. But this is also a challenge that must be addressed in many other places, regions of Europe. One of them, of the challenges and in the way forward, is the professional capacity. The lack of the enough trained professionals such as psychologists or social workers in oncology settings, it's a major barrier. There is a need for both more professionals and also for more specialized training in psychosocial oncology. The treatment integration always present, always on challenge, because integrating psychosocial treatments and needs in the routine care of cancer treatment protocols, it's still not a full reality everywhere. Here we are addressing system level changes that are needed to ensure that we are breaking down the silos for good in the benefit or for the benefit of the patient, and ensuring that psychosocial care is considered an essential part of the comprehensive cancer treatment. Communication issues are also an ever-present challenge, including the need for more transparent patient communication. And we must never forget being one but being different. The cultural factors that are always part of our lived experiences. And sometimes there is still present the stigma of cancer associated also with the cancer, I must say, but also with the seeking psychosocial help. And sometimes this is an important challenge, a barrier. And the high percentage of patients unwilling to discuss their cancer experience in our research also further emphasizes the challenge of implementing this kind of services. So this would be the challenges in our way forward. And for a more exact situation, under Romanian context, I think that would require integrating psychosocial needs, as I said, into the standard treatment protocols, providing the necessary training for oncology professionals, acknowledging the wider role that professionals like social workers and psychologists can play in the multidisciplinary teams, developing culturally appropriate interventions that are very much specific to the barriers that we are identifying in our research, and ensuring interventions that target the most vulnerable, particularly the elderly cancer patients, because they can get the most benefit out of these psychosocial interventions, always trying to address the economic factors that are impacting cancer access and quality of cancer care that we are receiving, and creating sustainable funding and implementation models for psychosocial services. And all these implementation changes and challenges are not only true for Romania. They might look like this and they should be tailored, but they are not, especially now in the European context, which require a very coordinated action across multiple stakeholders, including healthcare providers, policymakers, patient organizations, and the broader cancer community in Europe. And as I just mentioned, the European context and everything that happened after COVID holds some piece of hope for us. And the EU way of approaching mental health was, of course, part of a larger picture of the mental health care needs in Europe. And recognizing this, the European Union has put forward a comprehensive approach to mental health. And this approach was very much based on prevention, multi-stakeholder collaboration, and it crossed the traditional sector boundaries, the silos, and it actually aimed to put the mental health on par with the physical health. And so, actually, the European Commission approved a mental health budget in June 2023 of 1.23 billion euros, and it outlined 20 flagship initiatives that, of course, addressed many aspects of the cancer and mental health, but it was about promoting mental health, prevention of mental health problems, supporting the vulnerable groups, having national reforms, tackling the stigma, and also here I would like to highlight from the 21, at least 2 or 3 4 from the initiatives, highly top-rated initiatives that are important or relevant to the psychosocial needs of cancer patients. The flagship 12, which is Cancer Mission Platform for Young Cancer Survivors, flagship 13, which is EU-level initiative on psychosocial risks, and flagship 15, which is an initiative for more and better trained professionals in EU, or the flagship 18, which is tackling stigma and discrimination related to mental health. And all these kind of specific aims that are in these flagship initiatives that are relevant to cancer patients in mental health care. I would also like to mention just 1, 2, 3 of these projects: the Melodic project, the Altea project, the Implemental Joint Action, and so on. I'm very sure that with some of these EU-funded projects supporting mental health in cancer you are familiar already with. And these initiatives actually are demonstrating a growing recognition, and as I said, a beacon of hope at the EU level that addressing mental health, including the specific needs of vulnerable groups like cancer patients, is indeed a priority, requiring a comprehensive action, sustained investment, policy coordination, evidence-based approaches, and also integration with the broader health care systems. So, in conclusion, I would like to say that I have used in my presentation the psychosocial needs of cancer patients in Romania because this is where we have data for at least 24 years. It's a context that I am very familiar with. And also that we have a time span of what is actually reported related to the psychosocial aspects of cancer care in quality of life scores, and also how the transformations are still needed in this area to meet these needs. And we also highlighted that factors like age, cancer stage, financial status, physical activity, and illness intrusiveness are playing a key role in determining a patient's quality of life. Depression and other forms of distress are highly prevalent, and they significantly impact the well-being and of the cancer patients, and are often linked to other psychosocial factors like illness inclusiveness, lack of effective coping, and even sometimes not so good or clear, or I would say inadequate diagnosis disclosure practices. So I have used our example just to also put the path forward and to show one of the things that are important on the national cancer control plans as well, but also to have a broader push at the European level to keep continuing prioritizing cancer and mental health initiatives and supporting the populations like cancer patients with strengthening their mental health and with tackling stigma. And the last thing that I would say, and the final thought, is that in the end, effectively addressing the psychosocial needs of cancer patients is not just about improving their quality of life, though this is one of the most important thing, paramount thing that we can do. But it's also about the potentially influencing disease outcomes, progression, and survival. And I think that by bringing this absent voices into the front of the cancer care through research, policy, and of course integrated care, we can move closer to providing the truly comprehensive and compassionate support that is very much meaningful for everyone affected by cancer. Thank you so very much for your kind attention, and I am looking forward to your questions. Please contact me. You can find me, of course, on my official email addresses, but you can also find me on different platforms like LinkedIn, for example. So I would like to thank you once again. I'm out of time right now. And I would love to wish you a great afternoon and a great conference in Maribor. Bye. Thank you very much, Nevanka.